One early morning, medical student Jonathan heads into the hospital to round on his patient Mrs. Robertson, who just delivered a healthy baby boy the day before.
Good morning, Mrs. Robertson. This is Jonathan, the medical student. May I come in?
Sure thing, Jonathan.
I was wondering if you had any questions for me this morning.
Actually, Jonathan, I had a few questions about breastfeeding. I know that I'm making a lot of really good colostrum for Oliver here, but I was wondering what causes my breasts to make breast milk. Also, why do I get these strong uterine contractions when he starts to nurse?
Jonathan is being asked about the endocrinology of the milk letdown reflex. The objectives of this video are to describe the relevant maternal mammary and neuroanatomy involved in lactogenesis, review the endocrinology of the milk letdown reflex, and explain other systemic effects related to breastfeeding. The milk letdown reflex is initiated by the infant suckling at the mother's nipple. Recall that within the maternal breast are mammary glands consisting of alveoli that are lined with milk-producing cuboidal cells and surrounded by contractile myoepithelial cells. The alveoli eventually lead to the lactiferous ducts that communicate with the nipple. Also within the nipple are mechanoreceptor neurons that are stimulated when the infant latches and suckles the nipple. These mechanoreceptors send a nerve impulse to the mother's spine and eventually to the hypothalamus. This nerve impulse creates two important responses within the hypothalamus. The first response is to send an on message to the neurosecretory cells within the supraoptic and periventricular nuclei of the hypothalamus. The cell bodies here synthesize increased amounts of oxytocin that is packaged into granules. These granules then travel down the axons of these cells through the pituitary stalk and are released from the posterior pituitary. In this way, increased amounts of oxytocin are secreted by the posterior pituitary. The second response is to send an off message to the neurosecretory cells of the hypophysiotropic area of the hypothalamus that produce the neurohormone prolactin release inhibiting hormone, also known as dopamine. Prolactin release inhibiting hormone is continuously produced and carried from the hypophysiotropic area to the anterior pituitary by the hypothalamo-hypophyseal vascular system. Dopamine normally acts on the anterior pituitary lactotrophs to suppress the production of prolactin. With the downregulation of prolactin release inhibiting hormone from the hypothalamus, the anterior pituitary increases its production of prolactin. The prolactin made by the anterior pituitary lactotrophs then stimulates milk production by the cuboidal cells of the alveoli. The oxytocin produced by the posterior pituitary causes contraction of the myoepithelial cells, which causes excretion of the breast milk out through the lactiferous ducts and through the nipple. This is sometimes known as the milk ejection reflex and is evidence that the breast milk is excreted from the mammary gland rather than being sucked out by the infant. Regular emptying of the mammary gland is important to continue breast milk production, as a separate inhibitory paracrine peptide is secreted into the breast milk by the alveoli. This peptide is called feedback inhibitor of lactation, and it causes the cuboidal cells of the alveoli to stop secreting milk. Regular feeding and emptying of the breasts decreases the effect of feedback inhibitor of lactation, while at the same time also stimulating the regular release of oxytocin and prolactin from the pituitary gland. Interestingly, other stimuli from higher centers in the brain can also cause the hypothalamus to respond in a similar fashion to mechanoreceptor stimulation from the nipple. It is not uncommon for the sound of a baby's cry, or even the sight or smell of a baby, to initiate the milk letdown reflex. Breastfeeding mothers are sometimes surprised to have breast milk ejection from the nipple at the sight of baby photo advertising in grocery stores, or at the sound of someone else's baby crying. Other interesting systemic effects of breastfeeding also occur. Not surprisingly, the oxytocin secreted by the posterior pituitary also stimulates uterine contractions. This is the mechanism by which regular breastfeeding hastens uterine involution and decreases the risks of postpartum bleeding and uterine infection. Also, mechanoreceptor nerve impulses from the nipple act on other neurosecretory cells within a part of the hypophysiotropic area of the hypothalamus called the arcuate nucleus to inhibit the pulsatile secretion of gonadotropin-releasing hormone. This in turn decreases the production of follicle-stimulating hormone and luteinizing hormone from the gonadotrophs of the anterior pituitary. Similarly, Prolactin decreases the ovarian response to follicle-stimulating hormone and luteinizing hormone. Altogether, this causes a physiologic anovulation and amenorrhea of lactation that can last for 6 to 9 months in mothers who are regularly and frequently nursing their infants.
Those are great questions, Mrs. Robertson. As it turns out, placing your baby to breast causes your brain to make 2 important hormones that will cause your milk to come in. The first is prolactin that causes your mammary glands to produce the milk. The second is oxytocin that causes the mammary glands to squeeze the milk out of the nipple. Oxytocin also is the hormone that causes your uterus to contract when you breastfeed, and is the same hormone that was part of the stimulation of your labor contractions yesterday. With regular nursing of Zach there, you should notice your milk letdown and increased breast engorgement in the next day or 2.
Well, I guess me and this little guy here have a lot of work to do.
Ha ha ha! Sure thing, Mrs. Robertson, and a big congratulations to the both of you.